Thank you very much. Thank you very much. Thank you all for coming. Obviously, the day you will see is some basic stuff about POTS to help those of you who manage POTS patients both understand perhaps making a diagnosis, how we make a diagnosis and how we treat. And then obviously later on we will expand into some of the more complex and interesting areas of treatment and some of the associated features. So for some of you, this talk may be relatively basic, but I think always in this circumstance, it's quite nice to start off from at the same level. A lot of people I come across, a lot of physicians and allied health professionals have a very rigid view about how you diagnose POTS. It's a 30 beat per minute increase, that's it, thank you, good night. And I hope that I will give you an idea that it's not just that, even if it is that at all. So what is POTS? Well, to be honest, I don't think anybody knows, but obviously what we think it is an abnormality in cardiovascular physiology, getting blood to move upwards from your legs and from your abdomen to your heart and then up to your brain. And it may be a number of different problems. It may be an insufficient blood volume, so you're just underfilled. It may be a failure of vasoconstriction, so the blood vessels don't tighten. It may be that the blood is going to the wrong place at the wrong time in the wrong quantity. And it may be that the heart rate goes faster than it needs to. And it may be all of those things or a proportion of those things in our patients. And it has to be remembered that POTS is a syndrome. It is not one disease. So it may be different for different people. What that means is that what you do and how you investigate and how you manage each individual may be different from the next person who comes through the door. So a lot of my colleagues will find it very frustrating that I gave midodrine to this patient and they got better, so that's great, but I've given midodrine to the next patient, it didn't make any difference. There can't be anything wrong with them, they must be mad. But I think you have to think about it, that it's different physiologies, and so different people are going to react in different ways. So how do we make a diagnosis? The HRS guidance in 2015 was a fantastic document because for the doctors who tell their patients POTS doesn't exist, it's a condition made up by private cardiologists to make money, which one of my patients told me a few weeks ago, we can brandish this in their face and say, I'm not sure that the HRS would agree. So the HRS definition is lots of symptoms when you stand, symptoms that have been present for 6 months or more, and a significant heart rate increase on standing of more than 30 beats a minute without a fall in blood pressure. And that heart rate needs to be sustained. So this is not the significant heart rate increase as the blood pressure falls as people stand, which then disappears. This is a sustained heart rate increase. So that's fine, and lots of people, as I say, work on that principle of if it goes up by 30, you've got a condition. But I think what we have to remember is that heart rate changes are variable, so they will vary different times of the day, different days, different time of the month, whether you've eaten, whether you haven't eaten. This study from Professor Raj and colleagues wanted to compare whether tilt testing was as good or was better than doing an active stand. They're slightly different physiologies, but to make sure that it was done reproducibly, the patients were tested between 8 and 9 o'clock in the morning, they were fasted, their medications were stopped for more than 5 half-lives. That's not how you're going to get your tilt table tests when you request them. They're not going to be like that when you stand the patient up in clinic. So you can't necessarily say, just because they found more than 30 is the answer, that it's always going to be more than 30. What is very interesting, and Bob Sheldon summarised this at HRC this year, that actually when you look back at the original publication, of course we're not saying that what the team who described this syndrome were wrong, but actually that original paper was a retrospective review of patients at the Mayo between 20 and 51 years of age, where they had noticed that there was an orthostatic tachycardia, and they looked at 16 patients. And they defined this condition on the basis of the 30 being more than 2 standard deviations away from the mean heart rate increase. So to take a very didactic view to say it's 30 because that's what the guidance says is not entirely logical. It's not based on a lot of facts. So there's clearly the syndrome, but that 30 beats a minute is not set in stone. So I think that it's very important to remember that there are lots of fainty people. There are people who stand up and feel unwell, and we call those orthostatic intolerant, and POTS is a proportion of that. But we mustn't feel that there is this, that if your heart rate goes up by a certain amount when you stand, you've got POTS. There's a group of normal people, and the people in the middle are just barking mad and just making up the symptoms. It just isn't like that. There's a continuum. So it's about the heart rate increase, yes, but it's also got to be the right person. It's got to be the right symptoms. And they've got to have the tests that sort of tell you that this is the sort of thing that we're looking at, but also we're not missing something else. So that's making the diagnosis. So in general, we know that most of our patients are female and most are young, between 15 and 35. So when I get the referrals for, say, would you see this 75-year-old man with POTS, please? That patient isn't going to have POTS. That patient needs to be seeing our next speaker in her autonomic failure clinic. So younger women are the classical patients, and they present with these symptoms. So this comes from the questionnaire study that our American colleagues did of over 4,000 POTS patients. And you can see there's a wide range of symptoms, lots of cardiovascular symptoms, so most are presenting with some degree of palpitations, breathlessness, chest pain and so forth, but lots of other things as well, lots of bowel symptoms, lots of neurological symptoms, cold hands, feet, tingling, flushing, bladder problems. So a wide range of autonomic symptoms. So that means that we're not really going to diagnose proper POTS on the basis of somebody who has no symptoms at all. So the sort of suggestive things, because there's a lot of cardiovascular symptoms, the sort of suggestive symptoms we're going to hear will be chest pain, although the chest pain is not very well explained, and a lot of it is musculoskeletal, sharp and stabbing and suddenly hurts doc. But some of it is a tightness, and that probably fits in with a tachycardia, may well relate to the dysfunctional breathing, which we'll hear about later. That, again, seems to be a very likely cause of the breathlessness. A lot of patients will say that they're sighing and they're yawning and they need to gasp every now and again, and I'm not quite filling up my lungs. And when we look, we don't find a lot of problems with the lungs, but we find breathing pattern problems. A lot of the patients present with ankle swelling, but also purple feet. So purple feet, and you can see here this lady's got acrocyanosis, which comes from standing up, but then you compare that to her hand, which isn't dependent. You can see that there's a difference. They complain of palpitations, some ectopics, some SVTs, but mostly it is just a sense that the heart's beating, and often that it's beating faster than it should do. Obviously, in general, they're all complaining of feeling faint on standing, which all gets better when they lie down, but it's worse in the times when you would expect it to, so extremes of temperature, temperature changes when they're unwell after a meal. So we're expecting to hear some degree of all of this sort of cardiovascular symptomatology. We're then interested in, yes, doing a standing test. That might be an active stand, that might be getting them to stand in the GP practice, it might be using beat-to-beat blood pressure. This is a recycle slide, and I'm very grateful to Professor Raj for letting me recycle it. This comes from the European Cardiac Society guidance. So we're looking for a significant increase in heart rate on standing. Clearly, if it doesn't go up at all, we are somewhat suspicious. We're also interested in this blood pressure variability, and it's interesting that a lot of patients who don't necessarily fulfill criteria for POTS do still exhibit an awful lot of blood pressure variability. So we end up calling this orthostatic intolerance, and it may actually be that the blood pressure variability is even a better guide to these patients than the heart rate increase. So we do lots of tests. Anybody who's referred to me will know that we do lots of tests. That's just because we do lots of tests. This is certainly not to suggest that you must do these tests, but I think we've learnt a lot of things about our patients by doing these investigations. Obviously, every cardiologist will do an echo just to make sure it's normal. We do Holters because they complain of palpitation. But then patients are told it's normal. Oh, there's nothing wrong with it. There's no arrhythmia. But we're not doing the Holter for arrhythmia. Yes, we'd like to exclude it. But what we're interested in actually is the fact that the heart rate is just too fast. It's persistently fast during the day. Or it's very spiky. It's constantly changing. And it's going far too fast for the circumstances. So what's rather an inappropriate sinus tachycardia pattern, and I'm not entirely certain that there's a lot of difference between POTS and IST, to be frank. So the Holter gives us a good idea about what the heart rate trend is looking like. We do a lot of cardiopulmonary exercise testing, and I suppose when you hear about dysfunctional breathing, we'll hear a little bit more about that. Why we started to do this was because patients complain of exercise intolerance, and they complain of chest pain, and they complain of breathlessness on exertion, so the CPET seemed like a very good idea. And it gives us an idea about how well-conditioned patients are. You will know, I'm sure, if you've got involved in CPET, that it's incredibly complicated, so you have to have somebody who knows what they're talking about. But it was from this that we started to feel that dysfunctional breathing may be very relevant. Charlie will be talking to us about that later on. One of my colleagues has started to put together a series of our POTS patients with CPET, and these are just a couple of graphs from what she's produced. But what is very interesting is that an awful lot of our patients have all got lower end tidal CO2s before they start and while they're doing this. It means that they are hyperventilating. But it doesn't mean that they are anxious. I think this is abnormal physiology. But, interestingly, their VO2, so how fit they are, how well their cardiovascular system is working, actually, overall, is within the normal range. So the idea that POTS patients are just deconditioned is certainly not the case in our series. There is no doubt that deconditioning will play a role, but the idea that POTS patients are either just hysterical or lazy because they're just unfit just is not the case. We do blood tests, general screen, vitamins and minerals, because POTS patients do feel better when you make that better. Cortisol is important, an early morning cortisol. We've picked up a few Addisons. ENA to look for Sjögren's. We've only picked up one of those, but it seems, discussing with colleagues, that this is the autoantibody that is worth checking. I apologise to Professor Raj, who's not concentrating, for not asking your permission to use this, and I hope it's all right. But at some point, I imagine that this will hit the literature, which is this idea that POTS is not just about a heart rate. It's about a continuum of patients who have increasing symptoms and increasing degrees of orthostatic tachycardia. And the Canadian consensus, I hope when it comes out, will give us a much better idea about, yes, there are POTS patients, but there are also POTS patients who sound POTSy but don't necessarily fulfill the criteria. But there are also people who have tachycardias of other causes. So we're hoping that as time goes on, we'll become a little bit more clever than just that it's a heart rate of 30. So how do we make a diagnosis? You've got to recognise the patient with symptoms, the right demographic. It's more than just the heart rate change. Obviously, we've got to make sure we're not missing something else.